Okay, good morning, everybody. Please do fill up the seats all together, so don't leave any empty spaces. And this will be live. This will be live streamed to the other room. No?
It's streaming, yes.
Yeah. So it's streaming to the other room. So if you don't have room here, there's going to be live streaming in the other hall. So good morning to everybody, and it's going to be a really interesting session. My name is Paulina Salminen, and I will be chairing this together with Luis Ocaña and Ricardo Cohen, who's just arriving. There we go. Please join us. And it's going to be a really interesting session because we have chosen 3 best recent European papers, and we will have the presenter do their 10-minute presentation, followed by a first discussion with a few comments, and then hopefully we will have room for one question from the floor. Without further ado, we will start with the Norwegian trial. So I will invite Dag Hovsjø. Come up here, Dag, and present the Oseberg trial 5-year results.
Okay, good morning. First, I would like to, you can hear me? Okay. First, I would like to thank the President, Paulina, and the Chair of the Scientific Committee, Marco Buter, which have, on behalf of IFSO EC, given me the opportunity to present the results from the Oseberg trial. It's a great honor for my research group and for me personally as the principal investigator of the Oseberg trial. This is our funding, and I have no conflicts of interest. Oseberg is an acronym of obesity surgery in Tønsberg, which is referring to a famous Viking ship built in the 9th century. Sorry? No. We had 2 primary endpoints, one clinical, remission of diabetes, and one physiological, beta cell function, and I'm an endocrinologist. Secondary endpoints related to this presentation are remission of diabetes, body weight, blood pressure, lipid profiles, health quality of life, health-related quality of life, and reflux disease. Other secondary outcomes related to glucose homeostasis, bone health, nutritional intake, and liver steatosis have been published previously. And as of today, a paper showing a possible link between changes in the gut microbiome, GLP-1 secretion, and type 2 diabetes was published in Nature Metabolism. However, in today's talk, I'd like to focus on this publication from last year with my PhD student, Jostein Hauge, as first author. The Oseberg study is a randomized, controlled blinded single-center study. Sleeve gastrectomy, and they were randomized to sleeve gastrectomy or gastric bypass in a 1-to-1 ratio. All patients had type 2 diabetes and had obesity. Important exclusion criteria for this talk is erosive esophagitis, grade C or D, Barrett's esophagus, and a large hiatal hernia. The study was initiated in 2013 and then completed after 9 years in 2022. Importantly, also for the discussion, glucose, lipid, and blood pressure lowering drugs were adjusted according to a predefined algorithms. Our surgeon used 35 French bougies when performing the sleeve gastrectomy. The staple line started 4 to 5 centimeters from the pillars. They performed the standard gastric bypass with a 25 milliliter gastric pouch and an elementary limb of 120 centimeters and a belopancreatic limb of 60 centimeters. Having outlined the study methods, we can now turn to the results. Between 2012 and 2017, more than 300 participants were screened for eligibility. Approximately 1/3 were ineligible, 1/3 declined participation or had exclusion criteria, leaving 109 patients to be randomized. During the 5-year follow-up period, 8 patients in each group were lost to follow-up. In addition, and I know you are this is interesting for you. 3 patients were converted from sleeve gastrectomy to gastric bypass due to insufficient weight loss. Data from these persons were removed and not included in the analysis presented today. The participants in the Osberg trial were slightly older than participants in the general bariatric population, 48 years old. A1C was just below 8%, approximately 90% used glucose-lowering drugs, and 1 in 5 used insulin. The great majority was white. Nadir body weight was at 1 year, and the total body weight loss at 5 years was 22% after bypass and 17% after sleeve gastrectomy. A1C and the use of glucose-lowering drugs was reduced in both groups. At 5 years, both A1C and the proportion using glucose-lowering drugs were significantly lower in the bypass group. Okay, and with these 2 results in mind, let's see at the proportion of patients in diabetes remission. During the study period, the recommended A1C cutoff level for diabetes remission was changed from equal to or below 6% to below 6.5%. Therefore, we chose to present remission using both definitions. The entire bar represents the remission rates using the new consensus definition, and the lighter shaded part of the bar represents the old definition. Remission rates were highest at 1 year and higher, independent of the definition, in the gastric bypass group throughout the study period. Using the new consensus definition, approximately 1 in 3 in the sleeve gastrectomy group and 2 in 3 in the bypass group were in remission at 5 years. And also importantly, a sensitivity analysis including data from the 3 patients that were converted from sleeve to bypass did not alter our results. Looking at the right panel, you can see that the total cholesterol and LDL cholesterol were significantly lower in the bypass group, even though fewer patients were on statins in that group. At the right panel, you can see the blood pressure was reduced transiently, despite a reduction in the use of blood pressure lowering drugs. Diastolic blood pressure was slightly lower in the bypass group at 5 years. Okay, health-related quality of life. It was assessed by a generic questionnaire, SF36, and an obesity-specific health-related quality of questionnaire called Impact of Weight on Quality of Life, LIGHT. Both general and obesity-specific quality of life peaked after 1 year and then declined slightly thereafter. Physical health improved more than mental health, and patients in the bypass group had higher self-esteem at 5 years. Reflux symptoms was assessed by 2 questions in the gastrointestinal symptom rating scale questionnaire. The questions were, have you been bothered by heartburn or acid reflux the past week? Patient rating their symptoms from 1, no discomfort, to 7, very severe. There was a slight reduction in the reflux symptoms and a reduction in the anti-reflux medication in the bypass group. In contrast, there was no change in the reflux symptoms, and the use of anti-reflux medication increased in the sleeve gastrectomy group. However, these differences were not statistically different. A 24-hour ambulatory pH monitoring and an upper endoscopy was performed. Unfortunately, only 2 out of 3 performed the upper endoscopy, and only half completed the pH monitoring at 5 years. We found increased, as you can see, acid exposure time after sleeve gastrectomy and decreased acid exposure time after gastric bypass. At the same time, we found, and I will say maybe slightly surprising given the changes in acid exposure time, a reduction in erosive esophagitis after both procedures. One case of Barrett's esophagus was observed in both groups. So, taken together, 68% of the sleeve in the sleeve gastrectomy and 19% in the bypass group had pathologic reflux according to the Lyon classification. Sorry. Symptoms of early and late dumping increased from baseline in both groups. Symptoms of early dumping like sweating, nausea, were more common after gastric bypass than after sleeve. However, symptoms of late dumping did not differ, and finally, post-bariatric hypoglycemia was more common after gastric bypass. There were few early complications, and the number and type of late complications during the 5-year follow-up did not differ between the two surgical procedures. So, to conclude, in patients with type 2 diabetes and obesity, gastric bypass seems to be superior to sleeve gastrectomy regarding weight loss, remission of diabetes, reduction of total and LDL cholesterol, and gastroesophageal acid reflux. Post-bariatric hypoglycemia seems to be more common after bypass than after sleeve. And we believe that these results should be considered in the shared decision-making process before surgery. Thanks for your attention.
I will then invite the discussant to come up on stage. So for this one, it's Professor Katalin Kopeski. Maybe you take the mic at the end of the table, so then Doug can stay and reply to your questions. So we have a few comments from the allocated discussant, and then if we have time, some questions from the chairs or the floor. Katalin, please go ahead.
Yeah, thank you very much. I'm gonna start immediately because I prepared some questions. First of all, I would like to congratulate you for this study. That's a really very interesting study. Your work for so many years is important. You started from the idea that at that time it was no study, no RCT looking exactly to the remission of type 2 diabetes in a comparative cohort sleeve and gastric bypass. The others at the time were looking at the weight loss and as a secondary effect to the bypass. So I think that was a very interesting start for your study, and that is a premiere in this respect. So the results are obvious, very interesting for so many years, and most probably bypass will be the preferred option as you tried to invite for the patients with bypass, or the patients with diabetes. So from this perspective, yes, now I have the questions here. Your 2 arms, single-center, triple-blind RCT is a high-quality study, that's for sure. But my role here is to address the weak points of this study. I think this is the role of the discussant, and I want you, beside this congratulations and the strength of your study, to explain why at the baseline there is a sex difference, a gender difference at the baseline in your 2 cohorts. And I think you are aware about this.
Yeah.
It was favored the gastric bypass with more women in the cohort. And I was carefully looking to all your 3 papers that you published. And it's a significant difference that favors gastric bypass with more females. From the very beginning, it was no comment over the time in this respect. And we know that the remission, the weight loss for the female patients, it's predicted to be better rather than in men.
Yeah, if I can comment on that. Yes. Yeah. There are, of course, differences at baseline, but they are not statistically a difference. This is by chance. And gender may have impact our results. And another point that may have impact our result is a slight difference in A1C at baseline, favoring bypass.
Yeah.
So there is possible that differences at baseline may have influenced the results. That's clear. But they are by chance. And I will say that the magnitude of the difference in remission, I said 1 in 3 versus 2 in 3, is large. And I don't think that this difference can be explained by the baseline differences. So it may have been slightly different.
Yeah.
And also, comparing our results with other previous papers, addressing this in like the Stampede, like the New Zealand study by Murphy, although that was a banded bypass, and also by the band sleeve study, which will be presented later, clearly indicates that there are differences between the procedures, and that is in favor of gastric bypass.
Okay, there is another thing that's related to H1C. That's you got a mean and median in 2 different tables that I've looked to all your papers.
Yeah, they are not.
And the difference that was presented is 0.3%, and in fact is 0.5, again favoring gastric bypass with more and moved to the right interval for the sleeve. I mean, more severe diabetes.
Yeah. A1C is not normally distributed at baseline, so then we chose to present the median, not mean, but it is very common to present mean for A1C. That's the reason why we also presented it in the first paper.
Yeah, it's a recommendation to comment this in your papers, that I'm for sure you will continue to show us your results. And the last one is in respect with the reflux.
Yeah.
I've looked to your work. There is no reference to any hiatal hernia in time. And despite the fact that Barrett and GERD, the esophagitis, it's not significantly differently between them. But there is not a single word about hiatal hernia, which is expected to be so high. And I think it will be interesting to look at in time what's happening with these very patients.
Yeah.
What's your comment?
Yeah. This is, as I said, the data we had missing data quite a lot at 5 years. And the study is relatively small with just about 100 participants. So I think what you can learn from the reflux findings are limited, but I think when it comes to the reflux acid exposure time, the data are very clear. And as I comment, the finding with the esophagitis was quite surprising. And I must say also, patients with a large hiatal hernia were excluded prior to the inclusion of the study.
Yeah, I've noticed.
Yeah.
Thank
Thank you so much,
no
Ketil. Thank you. We have one more question from Ricardo, so thank you, Ketil.
Thank you. I have one very quick question. If you have to redesign this trial today in the current landscape of treating obesity and diabetes, would you put as an endpoint withdrawing medications? Because if you keep on the medications, you'll have better outcomes.
Yeah.
I still think it's favorable for the gastric bypass, but the sleeve would improve as well. What are your thoughts?
Yeah, that leads me into the discussion is whether remission is important, and we believe remission is important, but clearly also reducing A1C and reducing body weight with, for example, medications. It's also...
So you would redesign and remove an endpoint withdrawing medication. I think this is the message of
Yeah.
the Osterberg trial. No, thank you.
Yeah, especially nowadays.
Thank you, Doc. Thank you, Kathleen.
Yeah, thank you.
The next presentation is by Maud Robert from France on the efficacy and safety of the SADIS versus the Roux-en-Y gastric bypass, the SADIS sleeve superiority trial at 2 years follow-up.
So thank you for the invitation. I'm very honored to present this work, which is the result of the work of the French bariatric community, which is very active. And this is thanks to this community that we are able to do this randomized trial and that I'm able to present our results today. So these are my disclosures.
The slides are not changing.
Sorry?
The slides are not changing.
Sorry.
No. You can press the enter button.
Yeah.
That goes forward when you go. You get it? Can we have the slides up? There. Can we have the slides up?
Okay.
And then use that.
This one? Okay. Okay, so let's start. So the background when they designed the trial in 2017, the SADIS was described by the team of Madrid. The first endorsement was by the ASMBS in 2016. With the second endorsement by the IPSO was in 2018, and there was clearly a lack of evidence at that time, with no published randomized trial comparing SADIS with Roux-en-Y, a long-established and validated standard in bariatric surgery. So the SADIS sleeve trial was a nationwide multi-center randomized trial of superiority, comparing the SADIS versus Roux-en-Y gastric bypass. The main objective was to demonstrate the superiority of SADIS towards Roux-en-Y for weight loss outcomes using excess weight loss percentage at 2 years of follow-up. The surgical technique was performed as a primary surgery or after suboptimal clinical response of sleeve gastrectomy. And why we decided to include revisional cases is because you all know that sleeve represents more than 60% of all bariatric procedures with up to 30% of recurrent weight regain. So we wanted to have a population of the trial which is representative and results could be applicable to all our bariatric community. So the design of the surgery, for the SADIS, we have a tailored common channel, 300 centimeters if initial BMI was inferior to 50, and 250 centimeters if initial BMI over 50. For the Roux-en-Y gastric bypass gastric group, standard design, biliary limb 50, alimentary limb 1.5 meters, and it was all the trials in France designed like that, so we would be able to compare our data together. This is the design of the study. We started in 2018 in 22 high-volume centers. Randomization was equal, 1-to-1 ratio, stratified by center, previous history of sleeve gastrectomy, and presence of type 2 diabetes, as we know that these factors can impact weight loss. Main inclusion criteria was standard, BMI over 40 or BMI over 35 with comorbidities. SADIS as primary or as second surgery, as I said. We had the last inclusion performed in 2021 with 2 years of follow-up, and the last visit was performed in 2023. We analyzed weight loss, but also comorbidities, complications, quality of life, evolution of treatments, etc. So here is the flow chart. You can see that we included 190 patients in the SADIAS group and 191 patients in the Roux-en-Y gastric bypass group. We had about 12% of loss to follow-up, and finally we were able to analyze 144 data in the SADIAS group versus 159 in the Roux-en-Y gastric bypass group. So let's move to the characteristic of the population at baseline. So young population, as usual, 44 years old, mean BMI of 46, so quite heavy. The mean number of patients with type 2 diabetes, 26%. We also had 21% of patients with a previous sleeve included in the trial. 26% of patients with BMI over 50 and 31% of patients with type 2 diabetes. You can see here the mean HbA1c, 7.3%, but if you look at mean duration of diabetes, slightly higher in the SADIAS group, 7.7 years versus 5.7 years, and also more people on insulin in the SADIAS group, 36% versus 27%. So we did a post-hoc analysis to check that this was not statistically significant between SADIAS and Roux-en-Y gastric bypass, and it confirmed that there was no difference in both groups regarding duration and insulin use for patients with type 2 diabetes. So the primary endpoint, excess weight loss at 2 years. Here are the predicted trajectories. In red, the SADI. In green, the Roux-en-Y gastric bypass group. We found a mean difference between both groups of nearly 7%, which confirmed the hypothesis of superiority of the SADIAS group. We looked at total weight loss, which is now the common metric used in the literature, and we saw a mean difference in the primary analysis of nearly 3%, and more than 3%, 3.7% of difference at 2 years between both procedures in favor of the SADI with the sensitivity analysis. Then we looked at glycemic control as the secondary endpoint. So you can see in red the number of patients still on medication for diabetes, 36% in the SADIAS group versus 30% in the Roux-en-Y gastric bypass group, non-significant. Mean HbA1c, similar in both groups, 5.9% at 2 years in the SADIAS group versus 5.8% in the Roux-en-Y gastric bypass group. We had around 56% of remission in the SADIAS group at 2 years versus 61.5% in the Roux-en-Y gastric bypass group, and not significant at 2 years. So now the nutritional status. We saw no difference in mean albuminemia, mean intraalbuminemia at 2 years in both groups. We had nearly 12% of malnutrition, defined as serum albumin inferior to 30 grams per liter, or proalbumin inferior to 0.2 grams, or BMI inferior to 18.5 kilograms. So we also had one hospitalization in both groups, SADIAS versus Roux-en-Y, because of malnutrition. Here are data regarding vitamins. To resume, to synthesize this data, fat-soluble vitamins as vitamin A, D, E, and also vitamin B9 tended to be lower over time in the SADIAS group, but you can see that it was always over the threshold, which is with the dashed lines, and vitamin B12 tended to be significantly higher in the SADIAS group. Regarding surgical complications, here are the early surgical complications, so within the 30 days. More early surgical complications and statistically significant for the SADIAS group, with 3 leaks in the SADIAS group versus none in the Roux-en-Y gastric bypass group. we had, regarding late complications, more late complications in the Roux-en-Y gastric bypass group, 9.4% versus 1.7% in the SADIAS group, which is also reported in the retrospective literature. We had more internal hernia in the Roux-en-Y gastric bypass group, 2.6%, so five internal hernia, 4 occlusions, and also 4 acute anastomotic ulcer in the Roux-en-Y versus 1 in the SADIAS group. Looking at medical complications within the 30 days, more vomiting in the SADIAS group, 10%, probably due to the sleeve anatomy. We had also more diarrhea in the early days, 12% versus 5% in the Roux-en-Y, and also more dumping syndrome in the Roux-en-Y gastric bypass group, 10% versus 4% in the SADIAS group. Late medical complications, so over 30 days, less abdominal pain for the SADIAS group, 8% versus 14% in the Roux-en-Y, and still more diarrhea for the SADI, 22% versus 6% in the Roux-en-Y. Specific medical complications, we looked at kidney stones, no difference between both groups. We also looked at clinical GERD at 2 years, more GERD in the SADIAS group, 19% versus 8% in the Roux-en-Y gastric bypass group, with more use of PPI. Still less dumping syndrome in the SADIAS group. Overall complications, over grade 3, according to Dendoclavien classifications, 18% in the Roux-en-Y, 13% in the SADIAS group, not significant. And the duration of mean hospital stay was significantly higher for the SADIAS group, 4.8 days versus 2.8 days in the Roux-en-Y group. Secondary endpoints and now serious adverse events, complicated table. It means the serious adverse events which are significant requiring hospitalization. What we can see here is more abdominal pain in the Roux-en-Y gastric bypass group, 14% versus 7% in the SADIAS group. More diarrhea in the SADIAS group with 2 renal failure and 1 hypokalemia, so quite severe diarrhea for the SADI, and 5 internal hernia in the Roux-en-Y gastric bypass group, as I said previously. So then we did a post-hoc analysis to look at the impact of type 2 diabetes and history of sleeve gastrectomy, which were stratification criteria on weight loss trajectories, as we know that patients with type 2 diabetes or with a history of bariatric surgery usually lose less weight. And so you can here see with the dashed lines the weight loss for the global population, and with the solid lines the weight loss in the different subgroup analysis. And what is interesting is that the SADI is more efficient than the Roux-en-Y, especially for patients who have type 2 diabetes and who have no sleeve gastrectomy history. So SADI is particularly interesting in those patients who are diabetic and who as a primary bariatric procedure, nearly 12% of difference of excess weight loss. We also looked at the effect of excess weight loss and the type of surgical procedure on type 2 diabetes remission after adjusting for baseline diabetes durations and insulin use. As I presented previously, that it seemed that type 2 diabetes was more severe in the SADIAS group, so we adjusted this analysis. And what we saw is that there was no effect of the excess weight loss percentage on type 2 diabetes remission. There was a tendency to a higher probability of remission for the SADI compared to the technique of the Roux-en-Y, but not significant. We also saw that for each additional year of type 2 diabetes duration, the probability of remission decreased by approximately 7%, so probably disfavoring the SADI. And finally, also, the insulin use at baseline was a strong negative predictor of remission, as we all know, and so this was also not favoring the SADI. So as a conclusion, SADIS showed better results in terms of excess weight loss than Roux-en-Y at 2 years, so we confirmed the hypothesis of superiority. Comparable safety data, no severe malnutrition under, of course, appropriate supplementation and close follow-up. We had more early surgical complications for the SADI, but less late surgical complications. We had an increased rate of diarrhea, but also less dumping syndrome. The SADIS, as a conclusion, is a valid procedure, especially for patients without a history of previous sleeve gastrectomy, so as a primary procedure, and with patients who are diabetic. So thank you again to all the team who participate to this trial.
Antonio will be the discussant. Antonio, please be concise because we're running out of time.
Yeah, I'll try.
Do your best.
I didn't start.
I know, but
yes,
that's why.
Good. Okay, so thank you to the scientific committee for allowing me to be here, together with Dr. Robert Maud. First of all, congratulations to all the French team for having this paper and this study, Maud. I think the strength of the study are the following. First, randomized multicenter trial comparing SADI versus Roux-en-Y gastric bypass. I think it's including 22 bariatric French institutions. It's really multicentric. It's a high value, this study. Third, 381 patients, and more than 80% of following and maintaining during the study. 85% were 87% patients were anti-diabetic medication at the baseline, and more than 40% had under GLP-1 analogs. And the study going to be a very important piece of the point. And the primary endpoint was the percentage of safe weight loss at 2 years, and the post-analysis, as Robert said. This is the result. Just to point out that also in the two events, intention to treat and per protocol, the differences are significant, favoring SADIs, 76 versus 68, and 76 versus 67. And then here you can see, it's going to be even as primary analysis, as linear, and the second CT analysis and the complete case analysis, all is significant in favoring SADI procedure. And then here, another remark that Dr. Maud already said, which is the efficacy of the SADI procedure in those diabetic patients with no sleeve previously. It's another important piece of information. It means that the patient with obesity and type 2 diabetes, SADI procedure may be a nice option. And here you can see that. And again, even there is no significant data, they pointing out, they underline that the duration of the diabetes was 8 years in the SADIs versus 4 years in the Roux-en-Y gastric bypass. And the percentage of insulin was 36 versus 27. Going to be important. And then, so, however, as it's going to be from the discussion, they observed that for each additional year of type 2 diabetes duration before surgery, the probability of remission decreased by approximately 7%. And in addition, insulin use of baseline emerged as a strong negative predictor. And the limitation of the study. Of course, the inclusion of failed sleep patients, but as he said, it's the real life. Many patients have failed sleep are indication of studies. 20% of the cohort had missing data for the primary endpoint, but it was equal in both arms. The loop length, why to choose 50 centimeter viscomatic lead plus 150 alimentary limb, the Roux-en-Y gastric bypass, and 250 for patient BMI more than 50, and 300 more than less than 50, and the short follow-up, 2 years. So my question to you are, do you think that increasing the follow-up period would amplify those differences regarding weight loss, metabolic outcome? And regarding the safety profile you already mentioned, that's similar, but late complications are more frequent in the Roux-en-Y patient group. And even more important, the majority of these late complications needed surgical approach. Going to be another important piece of information. And again, thank you for the opportunity of being here.
So, thank you very much. A rapid answer. We are now studying the 5-year results. We are starting because all the patients have finished, so we will be able to give you answers quite soon. But probably I will say that on weight loss, probably the difference will increase over time. Well, it's a feeling. Again, it's not scientific data, probably. And regarding metabolic effect, I'm not sure, but as I said, probably these results were disfavoring the SADS as the diabetes was a bit more severe. So we'll see.
I think, because even the severity of your patient, the micro is, and I mean, they're going to be very important to define or to share with us, how important going to have longer follow-up in terms of, increasing, the differences in this well-designed trial. I think we need this information, Dr. Roy.
Thank you so much. We have like 2 questions, Maud. First one is because you said that the subgroup analysis, but your study wasn't really powered enough for that subgroup analysis, was it, to compare the different groups, right?
Yeah, it's a post-hoc analysis, so yeah, of course, it's difficult to...
It's clearly not powered, just wanted to clarify that.
Yeah, and I have another question, Maud. You have excessive weight loss 76% versus 67%, but your main secondary endpoint was diabetes resolution. What's the point of doing a SADIS if you have the same outcomes with the trade-offs of a higher incidence of malabsorption long-term with the SADIS? Why would you choose a SADIS over the bypass in a, quote, virgin patient? What's the point of a SADIS?
Both weight loss and type 2 diabetes. That's why we did this post-hoc.
But you showed there's no correlation of excess weight loss and diabetes resolution. So what's the point of incurring on a risk of malnutrition? As you showed, micronutrients deficiency are more prominent in the SADIS group. What's the advantage of SADIS?
But more weight loss. So this is results at 2 years. We all know that obesity is a chronic disease. So what we want is weight loss over time. So
but it's 2 years. At 2 years, you have no change.
Weight loss is important.
No.
Incretin effects, microbiome, another thing.
But there's no outcomes. There's no endpoint that show that SADIS should be chosen first rather than a gastric bypass in those patients. According to your data, maybe in real life, maybe wrong, but in the SADIS sleeve paper doesn't show that. Doesn't show any big advantage other than
on post-hoc analysis, yes.
That's not powered. That's not powered for that.
And what we demonstrated is in diabetic patients, which is an important message, is that SADIS is better than 1Y in terms of weight loss. And we know that all these patients with type 2 diabetes, they are reluctant to weight loss. So this is a strong message, I think.
There's no relation of weight loss and diabetes resolution according to your data.
Yeah, but not powered for that.
Okay.
Thank you so much.
Thank you.
Unfortunately, we have to move on. Yeah, Luigi, do you have a short question?
Very short.
Very short. Thank you, Antonio.
Don't you think that is unfair to compare the Roux-en-Y with the construction of 50 biliary, limb, and 150 alimentary? Because I think most of us, we are not doing anymore this kind of construction. It's most the opposite.
Well,
it is unfair comparison, I think.
I'm not sure. Probably these trials of comparison are not good trials anymore, as we are now moving towards medical therapy, towards multidisciplinary strategies, so probably it's just the design of the trial which is not the good trial actually in this world of moving things. But, well, if you want to have a standard, we use the standard and we compare all the new procedures as the standard. We have to have a standard.
Exactly. Thank you so much, Maud.
Okay, thank you.
Thank you.
The third speaker is Richard Welborn, coming from UK, with the interesting paper, Roux-en-Y gastric bypass, adjustable gastric banding, or sleeve gastrectomy for severe obesity. Thank you.
Good morning, Paulina, colleagues. Ricardo, thank you very much for the kind invitation to present the bi-band sleeve data today on behalf of the bi-band sleeve collaborative group. So when we first had the idea for this study, gastric bypass and gastric banding were about equivalent for their prevalence in UK bariatric surgery. So in the National Health Service, about 2/3 of the operations were gastric bypass, about 1 in 5 were bands, but altogether it was about 50-50, and very few sleeves were being done. So the idea for the study was born out of a conversation between me and Jane Blazeby, who is a surgical trialist working in the University of Bristol in 2009, when we were both chairing sessions at a Surgical Research Society meeting. She didn't do bariatric surgery. She's never done bariatric surgery. She asked me which was the best operation. I said bypasses. She said, how do you know? So as a result of that, we came to the conclusion that we should do a trial. So we put together a research team of surgeons, trials methodologists, endocrinologists, statisticians, and health economists. And the research question was to ask, to compare the clinical effectiveness and cost effectiveness of gastric band and gastric bypass. We added sleeve gastrectomy later on in the study, as I shall explain. The trial design was a non-inferiority hypothesis for weight and quality of life using as a superiority trial with dual primary endpoints. The margin for non-inferiority was chosen arbitrarily at 12% excess weight loss, and for a study to be shown to be superior, it had, for an operation to be shown to be superior compared to one of the other operations, it had to be non-inferior for weight loss, not exceeding the 12% excess weight loss margin, and superior for quality of life. We use EQ5D for the quality of life assessment because this enables us to do a cost-effectiveness analysis. So we started off the study in 2 centres. The funders didn't believe that we would be able to recruit between bypass and band. They didn't think it was possible to put patients into equipoise to recruit into 2 entirely different operations. So we started off as a 2-centre study. We proved we could recruit. Then we increased the study's centres to 4 and then 12. And we added sleeve to become a bi-band sleeve study. So we had a target recruitment of 1,341 patients. We exceeded that by 10, getting 1,351 patients. In addition to the dual primary endpoints of weight loss and quality of life, we had a raft of secondary endpoints, including a full economic analysis. So just to show you the timeline of how things developed, when we first started the study on the left, gastric bypass and gastric banding predominated. Very few sleeves were being done. It took some time to prepare the grant, to put the grant through to the funders. Eventually, the grant was approved in October 2011, and we were able to start the study in 2012. But by that time already, sleeve was increasing at the expense of gastric banding, and we realized that to make the study relevant to current practice, we had to include sleeve. So we put in a further application to the funders to add sleeve. That was eventually approved, and we started doing recruitment to sleeve in 2015. The study then finished 4 years later. This slide shows the overall recruitment to number when we first started recruiting. We weren't very good at recruiting. We recruited 2 out of our first 22 patients to bypass and band. We were then taught how to recruit and deliver equipoise between different operations. We did that. Our recruitment success increased to 40%, and eventually our overall recruitment rate was 30% of eligible patients. I haven't put up the exclusion criteria, but they are essentially there. Any patient with a hiatus hernia of more than 5 centimeters was excluded. Otherwise, patients were put into the study and considered eligible. So these are the results of the study. Talking about complications first, There was one mortality from a gastric band suture leak. There were quite a few adverse events in all the groups. The significance between them is that sleeve was the safest operation. It was safer than gastric banding and gastric bypass. There was no difference between gastric banding and gastric bypass. So sleeve was the commonest operation, and these were some of the selected complications. As you see on the right, there were 3 sleeve leaks, about 1%, as you'd expect from the literature. Quite a few bands were taken out during this course of the 3-year follow-up, and a few were converted to gastric bypass and 1 to gastric sleeve. In the gastric bypass group, there were quite a few internal hernias, and there were a few problems with the GJ anastomosis and the JJ anastomosis that had to be corrected. Okay, so these are the results for weight loss. This graph shows on an intention to treat basis and per protocol basis the difference in excess weight loss between the groups. 88% of patients had the allocated operation. 86% patients were followed up at 3 years, and the graph shows the proportion of patients achieving 50% excess weight loss at 3 years. Now, this graph shows the same data in a way that's slightly more easier to explain. The red line in the middle is the equivalence point. For an operation to be superior, it had to be to the right of the band, of the line, so sleeve was clearly superior to band, and bypass, as expected, was also clearly superior to band. What we didn't expect was that the sleeve weight loss would be inferior to the bypass weight loss, and it did not intrude on the non-inferiority margin. This was not expected, and therefore bypass was a clear winner in terms of weight loss over sleeve. About 10% of the patients are crossed over from one operation to another. 11%, as many as 11% of patients allocated to gastric bypass then decided they didn't want to do it and have had either a band or a sleeve. 16% of band operations chose to have another operation instead, including sleeves and bypasses, and 1% of patients having sleeve didn't actually have the sleeve. So this is the same data now shown as total weight loss, which is the current way of expressing weight loss. There are clear differences between band at the top, bypass at the top, sleeve and band. 26% weight loss for bypass, 14% for band, and 19% for sleeve. All of these are highly significant. So this is the EQ5D over time. This is the quality of life, and a higher score for EQ5D means better quality of life. Now, important to show you here is that the minimal and clinically important difference in EQ5D score is 0.03, and that equates to 10% weight loss. So as expected, gastric bypass and gastric sleeve were both clearly superior to gastric banding. The differences between gastric bypass and gastric sleeve were not significant, but the bypass had exceeded the 0.03 margin for improved quality of life. So looking at the health economic analysis now, in the UK we use health economics according to NICE. NICE is the National Institute of Clinical Excellence, and what they use is cost per quality as the margin for whether the threshold for whether something should be approved for use in the health service. We use a £20,000 and £30,000 quality thresholds. If something exceeds that, then it is deemed appropriate to use. If it doesn't, it's not appropriate to use in the National Health Service. So this slide shows the probability of something being cost-effectiveness at those thresholds. So with a £20,000 and £30,000 per quality threshold, the probability that gastric bypass is cost-effective is something like 80%. The probability the sleeve is cost-effective is something like 20%, and there is no possibility that gastric banding is going to be cost-effective. Therefore, on that basis, putting it all together, we concluded that, as expected, bypass and sleeve are more effective for gastric banding. Sleeve is inferior to gastric bypass for weight loss, with lower but statistically similar quality of life, and we recommend, certainly in the UK, that patients choosing the surgery are advised to have a gastric bypass. So there are several strengths of the bi-band sleeve RCT. We've shown that it's possible to recruit to a very large, pragmatic, generalizable trial in 12 different centers. It's directly relevant to UK practice. At all points in the study design, we had patient, public involvement. Data monitoring group and the trial steering committee all agreed that we should continue with the band and that we should add the sleeve. Surgeons learned how to deliver clinical equipoise. This is the only RCT to use EQ5D and therefore cost effectiveness and quality of life as a primary endpoint. And it's the only RCT, to our knowledge, to have full economic analysis. Clearly there are limitations. It takes a long time to set up the contracts. It takes time to do the ethical approval, and the duration of recruitment means the study is vulnerable to changing practice. There isn't time to discuss these, but we're all fully aware of the other studies in this area. And compared to the other studies, there are no significant differences in weight loss, but favored gastric bypass for the Dutch study, the Salmon and Finland study, and the SMBOS study of Ralph Patley, which has similar weight loss between gastric bypass and sleeve. So in conclusion, the sleeve, the bi-band sleeve study is the largest trial. It will dominate any meta-analysis, significant differences in weight loss, but obviously we need to do further follow-up. Many, many people to thank for this collaborative effort, 12 fantastic surgeons, 40 centers, 40 surgeons, and I should thank as well Jane Blaseby, who's a surgical trialist who managed to put it all together. Many thanks.
Thank you, Richard. We are going to take 5 minutes from the coffee. Paulina?
No, yes. Unfortunately, our discussant could not make it, but I'm sure we can think of questions to ask you. So thank you very much for the presentation. Could you tell me the rationale? One thing I never understood is that why you chose a categorical variable of under 50% excess weight loss and over, because that means that 49% is bad and 51% is good, because it is a number. It would be easy to use as a continuous variable instead of the categorical one. So could you clarify that?
Sure, that's an excellent question, and I take your point completely. When we designed the study, percent excess weight loss seems to be the thing to do. Times have moved on. We did consider changing the primary endpoint during the course of the study. When we made the statistical analysis plan, we discussed this a lot with methodologists and statisticians, and we felt it was best to continue with the existing categorical variable of choosing percent excess weight loss with the non-inferiority margin that we chose. We did of 12%, but obviously we presented the total weight loss as well.
Yeah, okay. And one more question about the data, because can you tell me what percentage was self-reported data? Because if I understood, unfortunately, not all the patients actually had clinical visits, right?
Yes, we were hit by the COVID pandemic, as everyone was during that time. There was some self-reported data, but by far the majority of the data was reported by independent clinic visits.
Richard, one curiosity. With the 3 papers on this session showed clearly that we have good options to treat obesity surgically. Saddle sleeve, the bypass. Why do you think surgeons still think that the sleeve is the best primary operation? Although the numbers are not increasing anymore, they're steady or decreasing, but why do you think it's in the mindset of the surgeon worldwide, the sleeve is the best option?
That's the billion-dollar question to which you don't know the answer.
That's why I see.
And we don't have the answer to that. In my centre for several years now, we have been doing Roux-en-Y gastric bypass. I accept entirely that with a gastric bypass, there are complications. We get the hyperinsulinic hypoglycemia, we get the internal hernias, we get the chronic abdominal pain, we get stomal ulcers, etc., etc., etc. But even though you put all those into the pot, gastric bypass is better according to the data we've shown. So I don't know why people... so the other question is financial, and maybe somebody can do 3 sleeves in a morning list rather than 2 bypasses and get more money for it.
And I think it's going to be really interesting because we are under the process of combining all the randomized clinical trials, including the UK ones, so all the ones that are comparing sleeve versus bypass, so that's going to be over 2,000 randomized patients and the Oseberg, so everybody is on board, which I think is great. Maybe with that we can find some prognostic factors that would be the optimal choice for a sleeve patient. Yeah, exactly. Thank you very much, Richard. Thank you very much, all the speakers, and congratulations on your excellent trials. Thank you. Hey, we should take a picture.